Okay, well, here we go. Sorry. So what I'm going to do is I'm going to go over this paper called Acute Myelitis as Neurological Complications, or as a Neurological Complication of COVID-19, and it's a case report and MRI findings. So what is myelitis? Well, that is inflammation of the spinal cord. So you can have things such as encephalitis, which would be inflammation of the brain. You can have myelitis, which is inflammation of the spinal cord. And then, so there are types of inflammation that can happen to the nervous system. So here they're saying that one of the effects of COVID-19 on this particular case study was myelitis, and they verified this through MRI findings. So I just want to go through this so that we can get an understanding of the possible neurological problems that coronavirus or COVID-19 can cause on the individual. So it might also be, so anything that can cause acute problems might also cause, chronic problems as well. So knowing that there can be some acute neurological inflammation that happens, that could clue us into whether or not there is chronic problems associated with the nervous system for coronavirus patients. So let's begin, and I'll try to go through this pretty quickly. So during the recent outbreak of COVID-19 caused by SARS-CoV-2 coronavirus, there is rising concerns about the neurological complications of COVID-19. I'll drink to that. So, fever, headache, and anosmia. And anosmia is when you cannot smell anymore, and by proxy, if you cannot smell, you cannot taste usually the same way. Anyways, these three may occur during the disease course. Other neurological sequelae, and I think these are symptoms, but sequelae are any condition or state that follows a disease, disorder, or injury. So a complication would be a good non-jargon way to say that. So other neurological complications such as encephalitis, which would be swelling of the brain, may occur in later phases. So this might be something that happens after the fact. So when people think that they are in the clear, it could be that they will show symptoms later. So we report a case of acute myelitis in a 32-year-old male COVID-19 positive patient who presented with a 2-day history of flu-like symptoms, then sudden onset of paraplegia. So, sudden onset of paralysis of the legs and lower body, typically caused by spinal injury or disease. So, sudden onset of paralysis, and that would take a lot of people by surprise. So, luckily, that doesn't seem to be a very common side effect. But what causes a severe or an acute side effect in one person, there's probably a mild version happening in milder cases as well. So we need to be vigilant on the severe cases, because the severe cases can tell us to keep an eye out on the mild cases if the mild cases have any similar complications that are just less severe. Anyways, continuing, and urinary retention. So this is when you basically can't empty your bladder the way you should. So the incidence is not known, and the pathogenesis of the disease behind this manifestation is still not fully understood. Nevertheless, considering the broad differential diagnosis of acute myelitis, prompt clinical and diagnostic workup was crucial to exclude other causes. So they were, since so many different things can cause myelitis, we were worried, or they were concerned, that maybe this wasn't a side effect of COVID-19. This might have been a side effect of a plethora of other diseases. So they wanted to rule that out first. Anyways, they did that. And patients presenting with neurological symptoms such as loss of consciousness, ataxia, which is when you cannot walk, your movement is screwed up, convulsions, and status epilepticus. I believe that is epileptic seizures, but let me, is a medical emergency associated with significant morbidity and mortality. Yeah, continuous seizures lasting more than 30 minutes. So status epilepticus is continuous seizures lasting more than 30 minutes. And encephalitis, which is inflammation of the brain, myelitis, inflammation of the spinal cord, neuritis, which would be just nervous, yeah, just inflammation of the nerves, general inflammation of nervous tissue, and all those should raise concern for COVID-19 infection during this pandemic, prompting early diagnosis and initiation of proper management, because the way that a lot of diseases go from bad to worse is if you have symptoms that remain untreated. So we can significantly reduce the rate of complication if we can catch diseases and symptoms early, and then we can start treatment for those symptoms earlier. So let us go. So COVID-19 continues to spread across the world with critical challenges for the public health and medical communities. As of May 2020, the number of confirmed cases globally has climbed to more than 5 million, and now we are approaching, I think, around 8 million, so they are already behind the curve. And the confirmed deaths, more than 350,000 cases worldwide. So all available evidence for COVID-19 suggests that it has a zoonotic origin, coming from animals. The sequence and the evolutionary tree analysis, also known as phylogenetics, has shown that SARS-CoV-2 is an enveloped, positive sense stranded RNA virus. And so enveloped just means that it has an envelope around it, so they usually have envelope proteins which help assist the cellular membrane of its host organism to have the cellular membrane basically butt out and allow the virus to use the cellular membrane or a membrane of the host organism. So here we're going through a case report. So a 32-year-old Asian man, previously healthy, so few underlying conditions probably, presented to the emergency department complaining of one day duration of sudden onset of bilateral lower limb weakness. So happening on both sides and lower limb weakness. So I'll look this up to make sure I'm not. Let's just look up lower limb weakness to make sure. Yeah, so so I don't know why they call it lower limbs rather than legs. If you are in the medical field, I might just be screwing this up, but I believe lower limbs means legs. But yeah, we'll leave it at that. There might be a specific reason why they're saying lower limbs, or I'm just stupid, and there might actually be a difference between lower limbs and legs. So if you are in the medical community, could you like enlighten me? Because I think I might be a little dumb here. Anyways, difficulty in sitting up and in passing urine. So this is what we were talking about earlier with the inability to urinate properly. So this would indicate some sort of neurological or muscular problem that prevents them from pissing properly. Anyways, he noticed these symptoms upon waking up from sleep in the morning, and there was no associated bulbar symptoms. Let me look up bulbar symptoms. So things such as difficulty swallowing, weak jaw, facial muscles. So this would be a type of palsy. So it's not it doesn't seem to be a symptom associated with palsies, and sensory deficit. So apparently he could feel things correctly. So this would indicate that it's not like the nerves are being pinched, which I believe is what causes some palsies. Perhaps the inflammation can also cause pinching of the nerves. I'm not in the medical field, so I'm stumbling along through this with all of y'all. Continuing on, nor upper limbs, weakness or back pain. The weaknesses involved the whole lower limbs proximally and distally equally. So what this sounds like, translating this, I think this means that the weakness happened. It wasn't like a progressive thing. It wasn't like there was a spectrum of weakness as it got further away. It sounds like if it was there was an area, basically an area where it went from strong to weak, and it was an immediate shift, and everything below that was the same level of weak. Granted, yeah, we'll just say that. Anyways, these symptoms were preceded by a 2-day history of high-grade fever and flu-like symptoms, which was not associated with shortness of breath or cough and was managed in the outpatient clinic. He denied any history of trauma or previous similar episodes. So usually a lot of people, if they have a history of neurological disorders, that can really expedite the process of medical staff of trying to figure out how to treat them. But he said, no, I don't have a history of trauma or any of these neurological issues. So there was no significant past medical or surgical history, and family history was negative for any neurological disorders. So they're going through the list trying to find a reason, and it sounds like the reason is COVID-19. For the most part, there could be something else that just springs up out of nowhere, but a lot of the things that would spring up, a lot of neurological conditions are hereditary to a degree, or they are associated with trauma to a degree, or they're associated with a disease. So if you are ruling out all these other things, at some point you have to say, okay, what, maybe this is a side effect. This might be a possible complication of COVID-19. Continuing on physical examination, the patient was vitally stable and febrile, so no fever. He was alert and oriented to time, so his sense of time was correct. Place and person, so he had his wits to him. So his chest auscultation, which I believe is the sounds coming from the chest, are clear, and heart sounds S1 and S2 were normal. So his pulse was normal. Abdomen was soft with a palpable distended urinary bladder. So distended urinary bladder, I believe, is when it's too large. So referred to urinary retention. So you basically can't pee. So there's urine that's building up. Urinary, yeah, it's just retention of urine, right? And usually due to muscles that fail to detect an increased pressure to excrete the urine. So, yeah, usually associated with the need to urinate. Anyways, a neurological examination revealed intact cranial nerve examination, intact sensory system examination, normal muscle tone in upper limbs, and hypotonic in both lower limbs. So what is hypotonic? So lack of tone? So a lower concentration of soluble. This is the chemical. I'm going to look up the medical definition just so that I'm not. What is it? Hypotonic, lower limbs, muscle powers. Hypotonic muscle medical definition. Yeah, so low tone, not a lot of muscle tone. So the muscle tone in his lower limbs, which I assume are the legs, are weak, so, or lacking tone. And muscle power in the upper limbs were 5 out of 5, and distally were 3 to 4 out of 5, while the lower limb muscle power was 0 out of 5 in all muscle groups. So this must be some scaling system that they use in the medical field that I'm completely ignorant of. But I would assume that 5 out of 5 is good and 0 out of 5 is bad. Anyways, there was also trunk weakness without involvement of the neck muscles. Reflexes were 2+ in the upper limbs and 1+ in the lower limbs. Plantar's response reflexes were equivocally bilateral. This is getting out of my field, so I'm getting more and more ignorant as this goes along, but we'll keep on pushing through. A Foley's catheter was inserted in the emergency department, and almost 1.5 liters of urine was drained. So put a catheter in, and if 1.5 liters drains out, there was probably a little bit of retention going on. So I'm sure that he was very happy to be able to get rid of that excess fluid. Anyways, the patient was admitted to the hospital as a case of suspected acute myelitis versus spinal cord infarction for further investigation and management. So infarction, I believe, is cutting off, like it's getting pinched. So obstruction to the blood supply to an organ or a region of tissue, typically by thrombus or embolus. So that could be the result of a blood clot that ends up cutting circulation to an area. So it could be spinal cord infarction, investigation and management. Anyways, a chest x-ray in the frontal view was done and was normal with no evidence of consolidation. I apologize, I don't know what the medical term for consolidation is. If you know, you can leave it. I'll say consolidation medical definition. A pulmonary consolidation is a region of normally compressible lung tissue that is filled with, okay, so this would be, so, for instance, the ground glass opacities that are seen in chest x-rays that are normally associated with COVID-19, those are areas where fluid has filled the lungs, and because they're filled with fluid, they end up they're more opaque when they have the chest x-rays done. So apparently, this person, by the time he went and got his chest x-ray done, there was normal with no evidence of consolidation. So it looked like his chest x-ray was normal. Anyways, there was pleural effusion. Let's look that up so that we're not stupid. Water in the lungs. So so no consolidation, no water in the lungs, and nor cardiomegaly. Cardiomegaly. So the heart was not. Cardiomega. That makes sense. So the heart was not enlarged in some way. Anyways, laboratory results showed normal white blood cell count. So I don't know what UL is. Just know that this is about 10,000 per unit liter. I don't know, but just know that these are concentrations. The hemoglobin was decreased, so there was a little bit low level of hemoglobin. That could be something. Inflammatory markers, C-reactive protein was elevated. So this is a marker of inflammation, and they can take a test to see. And so the C-reactive proteins, or the CRPs, it's a protein made by the liver, and CRP levels in the blood increase when there is a condition causing inflammation somewhere in the body. So it doesn't tell you where it's happening in the body, but it could be a good warning, or it's a biomarker for inflammation that is happening somewhere in the body. So that inflammatory marker, C-reactive protein, was elevated. However, the erythrocyte sedimentation rate was normal, which is that the rate at which blood cells drop down? Yeah, so the ERC is a blood test that measures how quickly erythrocytes settle at the bottom of a test tube. So normally red blood cells settle very slowly, and a faster than normal rate may indicate inflammation of the body. So that's interesting that one of the, so there's robustness in our tests, right? We have multiple tests to try to figure out, basically to pinpoint what type of disease you have or what types of medications we should give you. So there are a laundry list of different biomarkers that doctors and medical staff can look at to try to figure out what is wrong with you. And so there are some markers for inflammation. So the markers C-reactive proteins, those were elevated. So that would tell a doctor that you probably have some inflammation in you. However, the erythrocyte sedimentation rate was normal. That would indicate that there's no inflammation happening within you. So these biomarkers, they're great, but they're not perfect. They're not all-encompassing. There could be some special cases where biomarker tests might contradict each other. So we would call that probably a paradox, but really the truth is there might be a disease that just figured out how to screw up one while leaving the other biomarker normal. So yeah, there might be, you can't just trust one test. You need to have a multitude of tests to have a comprehensive understanding of what is going on in the body. Continuing, so D-dimer was high. So D-dimer is one of the waste products of blood clotting formation. So when D-dimer is high, that tells you that there's a lot of, that there might be significant blood clotting that's going on somewhere in the body. and coagulation profile PT and APTT and INR were prolonged. So I don't know anything about these, but I'm guessing that these are, what would you call it, other biomarkers that would indicate some issue with coagulation. So anticoagulant proteins, protein C, antithrombin 3, and activated protein C resistance were within normal limits except for a mild decrease in protein S, which is at 42%. So in your body, you will have coagulation, you will have compounds in your body that increase the rate of coagulation, and you have other compounds in your body, proteins, hormones, just chemical messengers, if you will, and they some of them will be anticoagulant. So there is a balance between all of these that keeps you in homeostasis so that you only will form blood clots where you need it, and your blood flows smoothly all other times. And so they're saying here that the procoagulation profiles are increased or prolonged, and the anticoagulation profiles are decreased. Or sorry, are the same, except one of them is decreased, which is protein S. And creatine phosphokinase, or CPK. So you probably have taken creatine before as a supplement in order to get larger at the gym, get swole. So creatine, as a part of a way to, what would the word be? Part of your metabolic pathways to help maintain energy stores in the cells is creatine. Creatine is one of the chemicals that facilitates the process of storage and transport of energy. And creatine phosphokinase is one of the enzymes that will take creatine and then turn it into creatine phosphate. Now, creatine, well, I'll look this up, but creatine phosphate, if it is elevated in the blood serum, then that would mean that there might be damage in your muscles or your heart, because when the cells die, a lot of them will release the proteins that are within them. But if if your heart cells die or if your muscle cells are dying, those muscles have a lot of creatine kinase. And so if you can sense creatine kinase in the blood, that probably indicates that some muscle tissue is dying, or at least getting inflamed, which is causing the death of some muscle tissue. So yeah, this is basically what creatine kinase does. It takes your creatine that you spend way too much money for, and then it will basically take ATP, turn it into ADP, and then add this phosphate group to the creatine, but it's a reversible process. So this entire process is regulated to help maintain proper ATP stores in the cell. So this is a very important, this is an extremely important, what would you call that, way to regulate the energy in your body. So, and procalcitonin, and trying to remember what procalcitonin does. I think it's just involved in calcium modulation. And unusually high procalcitonin levels are found in patients with severe sepsis and septic shock. So this would be a way to, so if you have a lot of infections in your blood, that would be sepsis and septic shock. So somehow that releases prolactonin. So these are all biomarkers, right? So they're just giving you the results of their study so that other doctors can look at this and say, oh, I should look or test for these biomarkers if I'm presented with a patient, because they might line up, at least to a degree. And ferritin levels were within normal range. So apparently these can be high in some severe cases, but I believe people who have died in the morgues, ferritin levels are higher, and ferritin is one of the proteins that help transport iron throughout the body. Anyways, a PCR nasal swab gave a positive result for the novel coronavirus. And other viral PCR screenings include all of these, and they all were negative. So it is possible that he had a different virus. So they tested for all of them, and it looks like the only one that he did have was COVID-19. And you could imagine if he had one of these other viruses that might tell the medical community, oh, you got to watch out for, there might be a condition that arises when you have a co-infection of two diseases, COVID-19 with one of these. Because, you know, these viruses, they're all modulating your metabolism, so it is possible that if you have two at once, it could really screw you up. Anyways, autoimmune immunological screening was positive for lupus anticoagulant. So this is a misnomer. So lupus anticoagulant is actually a procoagulant in the body. So autoimmune immunological screening was positive for lupus anticoagulant. So lupus anticoagulant, this is a general term, and this is an antibody that your body makes that attacks something in your body that one of the hormones, presumably, that hormones or one of the proteins that is involved with blood clotting, and it interacts with it in a way that makes it more likely for your blood to clot. So here, they're saying that he tested positive for these antibodies that can cause clotting. Now, is this the result of the coronavirus undergoing molecular mimicry in order to encourage clotting? I don't know if they will discuss that at all, but yeah, that could be a possibility. So viruses can cause autoimmune diseases. So just get that in your head. Viruses, if they mimic your proteins enough, they can initiate autoimmune diseases. Anyways, and in conjunction with the low protein S levels, and protein S is a protein that is involved in clotting. Let's look this up. I looked this up earlier, but so it's a vitamin K dependent plasma glycoprotein synthesized in the liver, and it exists in two forms: a free form and a complex that is bound to the complement protein C4b binding protein. And so function, it has a role in the anticoagulation pathway where it functions as a cofactor to protein C in the inactivation of factors VA and factors 5A and 8A, and only the free form has cofactor activity. So basically, and let's look up lupus anticoagulant as well, because I believe that there was good stuff to know there. So lupus anticoagulant, as I said earlier, it's an immunoglobulin, and it binds to the phospholipids and proteins associated with the cell membrane. So I believe there seems to be, it could be many different types of antibodies that can accomplish this. So what this antibody is doing is it is attacking your cell membrane. So the phospholipids are the components of your cellular membrane. So if you have antibodies that are attacking the cell membrane in some way, this can initiate blood clotting in some cases. And here they say lupus anticoagulant is a misnomer and is actually it actually has prothrombotic activity. Lupus anticoagulant in living systems causes an increase in inappropriate blood clotting. So, and this is where the name is confusing. The name derives from the properties in vitro. So in a test tube, if you have these antibodies collected, they can increase. As these antibodies increase laboratory coagulation tests, such as the APT. Basically, they are anticoagulant. They have anticoagulant activity in very controlled test tube studies, but apparently in vivo, in actual living organisms, they tend to be pro proclotting. So they have this person tested for the proclotting antibodies, and he also tested with low protein S, which is an anticoagulant protein. So he was in a procoagulant state, is what I'm trying to get at. So the hematologist advised repeating the test after 12 weeks, as this result might be due to the anticoagulation treatment that the patient has received. So sometimes you can receive anticoagulation treatment, and that can screw up your hormones, right? So the hematologist suggested that they do the experiment again to make sure, to find out whether or not this is long-lasting or not. Anyways, other tests such as anti-neutrophil cytoplasmic antibodies, rheumatoid factor, anti-cardiolipin, and anti-beta-2 glycoprotein were all negative. So these are all different autoimmune disorders, and you can do tests for the autoantibodies, as they're called, and if you could imagine, if this person tested positive for any of these other autoantibodies, that could be of some concern. But it appears as though it is not, these other antibodies are not in high enough concentrations to elicit a response. Continuing, an urgent gadolinium-enhanced magnetic resonance imaging of the whole spine, and gadolinium, this is just a metal that is able to help with the contrast of these MRI machines. So gadolinium is magnetically relevant. I believe it. Let's look this up so that I'm not like giving you bullshit, but I believe it's able to interact with the MRI to increase. Yeah, it's a contrasting agent. So find gadolinium. Yeah. So they're usually gadolinium base, and such MRI contrast agents shorten the relaxing times of nuclei within the body following an oral or intravenous administration. So the relaxation time, so in an MRI, there's a very strong magnetic field which causes a lot of the electron spins of your atoms to align with the magnetic field, and then there is a pulse of some form of radiation which knocks those, it'll knock all of the electrons out of sync with the magnetic field, and then as those electrons realign with the magnetic field, they create a signal, and that signal is what is measured to recreate those MRI scans. So gadolinium is one of the, gadolinium is a compound that interacts itself with the magnetic field and can help speed up the rate at which the electrons in your body realign with the magnetic field. And by doing that, it increases the contrast. So just keep that in mind when you are reading this gadolinium enhanced magnetic resonance imaging. Just know that that is just an MRI. And this was done of the whole spine and revealed extensive, diffuse, hyperintensive signal involving predominantly the gray matter of the cervical, dorsal, and lumbar regions of the spinal cord. So extensive, diffuse, hyperintensive signal. So what is that? So I can read all these words, but there's always medical jargon. Hyperintensity refers to areas of high intensity on types of magnetic resonating images. Oh, and these are produced largely by demyelination and axonal loss. So remember, myelin is the protein that coats the surface. So you know how the nerve cells are long? So myelin is the protein that coats the long, stringy part of the neuron, of the nerves. And so you can undergo demyelination, and that protein is there to help conduct the electrical signal across the nerve cell. So you can have events where that myelin can be damaged. So things such as multiple sclerosis would be an instance where an antibody is actually damaging the myelin, but there are other reasons why it could be damaged. And that damage would make the nerves be less able to conduct electrical signals. And so in the case of in the case of an MRI, we can actually see demyelination events based on it's called hyperintensity. So, and apparently you can see it here. I'm guessing it's the really white parts. I'm not a doctor. I'm not a radiologist. I'm not a MRIologist. So just keep that in mind. I'm speaking out of a place of ignorance. But anyway, so extensive diffuse probably means there's a lot of it and it's not concentrated in one area. It seems to be diffuse, spread out across the whole spinal cord. Anyways, revealed extensive diffuse hyperintensive signal involving predominantly the gray matter of the cervical, dorsal, and lumbar regions of the spinal cord. So mild enlargement and swelling of the cervical cord were also noted. So no evidence of spinal cord or nerve root enhancement upon conscious administration was seen. No evidence of spinal cord or nerve root enhancement. I'm going to look up nerve root enhancement, what that means. What is the nerve root? Signal of a nerve leaving the central... You know, a spinal nerve root is the initial or proximal segment of one of 32 pairs of spinal nerves leading to the central nervous system of the spinal cord. Each spinal nerve is formed by the union of a sensory dorsal root and a motor ventral root, meaning that there are 62 dorsal ventral root pairs and therefore 124 nerve roots in total, each of which stems a bundle of nerve rootlets. Oh, okay, so these are the things that are coming off the spinal cord. Okay, so we're not going to get too much into physiology because I do not know that much of physiology. So anyways, no evidence of spinal cord or nerve root enhancement upon contrast administration was seen. Anyways, diffusion-weighted imaging, DWI, and apparent diffusion coefficients, ADC, show restricted diffusion. So no apparent hemorrhagic components were depicted. So conus medullaris appeared normal. What is a conus medullaris? Okay, it's this part of the spine then. So everything seems normal, but in the spinal cord itself, there seemed to be some enlargement, and there seemed to be demyelinating events, or something like it that would cause these hyperintense signals. So here you can look at the MRIs if you want, but I obviously do not have the capability of understanding them. I mean, does that look, that looks a little bent to me? I don't know. Anyways, let's go down to here. So findings were suggested of acute myelitis likely as direct damage or a sequelae or a complication of a post-infection process, so something that's not happening during infection, of the novel coronavirus. So, but, you know, this should be in question too, because just today I released a video talking about how some people might actually be testing positive for up to 92 days after their symptoms kick in. So, is that actually what's happening for most people, or is that just the rare case? Where they just happened to follow this person for 92 days and kept on getting repeated positive results. Who knows? I don't think that we're collecting enough data to make those judgment calls yet. But let's continue. So, or a sequelae, a post-infectious process of the novel coronavirus, as all other commonly associated viruses and immunological disorders were excluded. So all the other common causes for a complication like this have been excluded. So the only new thing, the only strange thing is the coronavirus And so they presume that that's probably the most likely scenario, which makes sense because there does seem to be some neurological diseases that are associated with contracting the coronavirus. Anyways, spinal cord ischemia, which is that's swelling, right? Oh no, inadequate blood supply to an organ. So ischemia is the inadequate blood supply. So spinal cord, lack of blood supply, or infarction, which I thought meant the same thing. Yeah, obstruction of the blood supply to an organ, typically by thrombus. So infarction would probably indicate by a blood clot, but ischemia could mean any just inadequate blood supply. So infarction would be a subset of ischemia, where this is caused by a blood clot. That's my understanding. If you're in the medical field, you can correct me kindly in the comments below. And this was less likely as to the MRI findings. So they were looking for this, but the MRI findings suggested no, that's not actually the case, or less likely to be the case. Anyways, he was started on a pulse dose of IV methylprednisolone, which I believe is an anti-inflammatory steroid. Yeah, it's a corticosteroid. It's a steroid, and it's there to help relieve swelling and redness. So yeah, I was right about that. Acyclovir and enoxaparin. Yeah, whoever comes up with the names for these drugs, my word. So if we want, we'll look this up because I'm curious. So I love how Wikipedia has all of the medications on them. It's an antiviral medication, and it's used for the treatment of herpes simplex and chickenpox and shingles. Oh. Other uses include prevention of cytomegalovirus infections following transplant and severe complications of Epstein-Barr virus. Okay, well, they gave that, even though we don't know if that works or not, but that's interesting. And then let us do... Oh, so this is a heparin analog, I believe. Yeah, used to prevent deep vein thrombosis, so deep vein blood clotting. And what is the... Yeah, so interesting. So yeah, this is an anti-blood clotting thing. So I believe this looks like heparin to me, but I could be wrong. Yeah, okay, yeah. Enoxaparin is in the low molecular weight heparin family of medications. So it is, apparently there's a lot of, heparin is a polymer, a highly sulfated polymer, and apparently it's associated with the signaling for blood clots and not. And apparently there are multiple medications that mimic heparin, either probably as antagonists or agonists, I'm guessing. So good to know. So a day after admission the patient became tachycardic and tachypneic. Let's look these up because, yeah, so very, very fast heart rate, and tachypneic would be excessive breathing. So I'm guessing tachy is Greek for fast. So this is a very fast heart rate and a very fast breathing rate. And considering the elevated D-dimer levels, or the elevated blood clotting levels, a pulmonary CT angiography was done to rule out the pulmonary embolism. So what is a CT angiography? Tesla uses X-rays to provide detailed pictures of the heart and blood vessels that go to the heart, lungs, brain, kidneys, neck, lungs, and arms. So there is that. And I wonder, and it was done to rule out, and it reveals a filling defect completely, wait. What is a pulmonary embolism? I need to look that up as well. I think that's a heart, sudden blockage of the heart, Okay, sudden blockage in the lung artery, and it usually happens when a blood clot breaks loose and travels to the bloodstream to the lungs. So this would be a blood clot that travels into the lungs, a pulmonary embolism. So they were doing this pulmonary CT and angiography to see whether or not there was a pulmonary embolism, and it revealed a filling defect completely occluding the posterior and lateral basal segmental branches of the right lower lobe pulmonary artery, and a partial thrombus in the right interlobular artery and in the basal segment branches on the lower left lobe. So I believe you can see that here. Figure for A and B, pulmonary CT angiography, maximum intense projection, segmental upper and lower lobe thrombi in the right pulmonary artery. I can't read these, but I'm sure a doctor would look at these and say, yes, there is blood clotting that's going on in these major arteries that go to and from the lungs, but I don't have the ability to do that. Anyways, the RV-LV ratio was normal. No areas of consolidation or pleural effusion were observed. I forgot what pleural effusion is. Yeah, so there was no water in the lungs, or no consolidation and no pleural effusion. So none of the ground glass opacities, none of the water was filling the parts of the lungs. So yeah, that's good at least that the normal symptoms of COVID-19 were not there. Anyways, the patient was commenced on a higher dose of enoxaparin and was not done. LP was not done as the patient was started on anticoagulants for pulmonary embolism. So he did, in fact, have pulmonary embolism, which is very unfortunate. But, you know, we are now learning more and more about this virus, and it seems that specific blood clotting agents or blood anticoagulant agents are effective. So soon afterwards, the patient's general condition improved and his vitals stabilized. Creatine phosphokinase, CPK, and procalcitonin also normalized, so this is good, which means there was less damage of the muscle tissue. And so he healed from that. And a marked improvement of his neurological deficit was noted over a period of 5 days of treatment with IV methylprednisolone. And he regained power in his upper limbs and bilateral lower limbs. He was also started on bladder training. So he healed, which is excellent. This is great. So discussion. The clinical manifestations of COVID-19 are highly related to inflammation of the respiratory tract, with the most common symptoms including a high-grade fever and cough that can rapidly be complicated by acute respiratory distress. So such cases are hypothesized to be related to a cytokine storm. So the cytokines are either pro or anti-inflammatory cellular signals, mostly released by the immune system, and a cytokine storm would be when that becomes dysregulated and can cause a hyper-pro-inflammatory state in the body. Anyways, this overproduction of early response pro-inflammatory, with overproduction of early response pro-inflammatory cytokines, there is an increased risk of vascular hyperpermeability, multi-organ failure, and eventually death in these patients. So I'm assuming this is when your blood vessels are very leaky. Yeah, the excessive leakage of fluid and proteins from blood vessels into the interstitial space. So yeah, that is just highly leaky blood vessels. So cytokines and, well, some cytokines, and I should say there's a lot of cellular signaling that can make the blood vessels leakier, and it can be very beneficial for your immune system to try to squeeze through to try to attack a pathogen that's in your body. However, if it goes overboard, it can end up damaging your body, because if your blood vessels are too leaky, there's too much stuff that is going to be flowing back and forth. So it's good for this process to be well regulated. Anyways, you can also get multi-organ failure and eventually death in these patients. There's also disruption of the procoagulant-anticoagulant balance. So remember, this is what I was talking about earlier. You have some compounds, some cellular signals, some biomarkers that are procoagulant and some that are anticoagulant, and that there's a fine balance between them so that you only get blood clots in areas that need them, such as when you cut yourself, and that the blood doesn't clot everywhere else, but this disruption can cause blood clots in different areas of the body, so we should be testing for these pro and anticoagulant factors in the body. Anyways, this increases the risk of developing microthrombosis and disseminated intravascular coagulation. So spread out coagulation throughout the entire vascular system. And this is, thus, as with our patient, pulmonary emboli are more prevalent. So they found the pulmonary embolism in the lungs through that CT scan. Anyways, in a cohort study by these people, it was found that more than 95% of COVID-19 patients had elevated D-dimer levels and fibrinogen levels. Fibrinogen is the, so fibrin is the blood clots, is the protein that creates the blood clots. Fibrinogen is the precursor to fibrin. And so thrombin will, if thrombin is activated, thrombin will attack fibrinogen and turn it into a form that will polymerize into fibrin. So blood clotting is a highly coordinated, regulated process. And fibrinogen is one of the starting materials to make a blood clot. Anyways, almost 87% had positive lupus anticoagulant during their ICU stays, so they are making an antibody that is attacking their own phospholipids. That is a problem, and that can cause coagulation. I'm guessing what could cause this would be if you have a bunch of cells that are dying and releasing their phospholipids into the environment. It could be that some of those phospholipids will activate certain immune cells that maybe they're not trying, but they just by chance happen to have an antibody that recognizes those phospholipids or that cellular membrane component, and therefore they end up creating more antibodies, duplicating, creating more antibodies, and then causing this these antibodies to attack more cell membranes and therefore cause coagulation. So 87% of positive lupus anticoagulant were positive of this autoimmune disorder during their ICU stays, as to our patient. So their patient agreed with the 87% in this Helms and others, that in a cohort study that was conducted by Helms and others. In another study by these people, lupus anticoagulant was positive in only 45%. It was also worth mentioning that there is a well-documented transient increase in lupus anticoagulant in cases of acute infections associated with a number of viral infections, such as hepatitis C, HIV, cytomegalovirus, varicella zoster. I believe that is chickenpox. Yeah, chickenpox, Epstein-Barr virus, adenovirus, and parvovirus. So this might be why they gave, what was it? One of the drugs that they administered to him, we looked at this up, was a general antiviral, and it worked on a lot of those other viruses that they just listed off. So yeah, I do not. Oh yeah, so acyclovir, that was an antiviral that was effective at a lot of those other viruses that were listed. So these people probably reasoned this high lupus anticoagulant factor was positive in their patient. And we know that these other viruses can increase lupus anticoagulant factor, or anticoagulant factor. And so they thought maybe the antivirals that are good at attacking all of these viruses might also be good at attacking SARS-CoV-2. So I'm guessing that was their rationale at prescribing that particular pharmaceutical. Anyways, recently a few studies have described neurological complications associated with COVID-19, and a retrospective study done in China by Mao and others has reported COVID-19 associated neurological symptoms involving both the central nervous system, the CNS, and the peripheral nervous system, the PNS, in 214 patients. Headache, dizziness, impaired consciousness, ataxia, which is the inability to move properly, acute cerebrovascular disease, and epilepsy were the most commonly reported cases of neurological complications of COVID-19. Central nervous system manifestations were more common in the more acutely ill patients. So the more ill they were, the more acutely ill, there appeared to be more central nervous system manifestations. Now, is that because the virus is purposefully attacking the nervous system, or is that just one of the side effects? Is it an autoimmune attack? That is possible as well. So it's really hard to know all the complications that can arise from a novel virus. Anyways, there were a few recent case reports also associating of SARS-CoV-2 with acute encephalitis in these patients who have symptoms of impaired consciousness. There has also been reports by Zhao and others associating COVID-19 viral disease with Guillain-Barré syndrome, and where neurological symptoms occurred without any preceding respiratory symptoms, suggesting a para-infectious rather than a post-infectious neuronal injury. So let's look up what Guillain-Barré syndrome is. It's a rare disorder in which your body's immune. So this is what I was talking about earlier, where it could be an autoimmune disease, and this is one where the immune system attacks your nerves. So weakness and tingling in your extremities are usually the first symptoms, and these sensations can quickly spread, eventually paralyzing your whole body. Don't like that. Sometimes I have some tingling, and I'm like, it hurts a little bit. So that, you know how when you go on to, what is it, a WebMD, and you type in your symptoms and you realize you have a life-threatening disease? That's what I feel like when I look up some diseases sometimes. Oops. Anyways, I'm gonna look this up because I think that that'll be beneficial. So I'll come back to this. So where neurological symptoms occurred without any preceding respiratory symptoms, suggesting a para-infectious rather than post-infectious neuronal injuries. So this is suggesting that the infection for this Guillain-Barré syndrome-like thing is happening while the person is getting infectious, so occurring at the time and association with an acute infection. So para-infectious in contrast to post-infectious neuronal injury. So I will definitely come back to this because this is reminding me of there are some coronaviruses that can very directly cause demyelinating events. So mouse coronavirus, I think it's called a mouse encephalitis virus or something of that sort. Don't quote me on that. Those are directly implicated in being able to cause demyelinating events in mice. And in fact, a treatment for that is the administration of beta-endorphin shortly after infection. So that might be a benefit that would help prevent this particular demyelinating event happening in this person as well. That someone really should look into that, because these demyelinating events can happen in different coronaviruses, and they are, at least in model organisms, it seems that it is very similar to this Guillain-Barré syndrome. So yeah, that should be looked at. Anyways, the incident of acute myelitis associated with COVID-19 infection in I think they meant to say is unknown. 3 case reports of similar cases were published in the literature up to the current date of writing this report, linking COVID-19 to acute myelitis as a neurological complication. So yeah, very, very few people. This guy's the 4th, right? The first is in Wuhan, where COVID-19 was first reported by Kang Zhao and others. The second in Boston, where the patient presented with symptoms of upper respiratory tract infection, then developed acute myelitis 7 days later, so quite some time after. And nevertheless, it is still debatable whether the myelitis occurs directly from the viral infection or as an autoimmune complication. So this is, I'm leaning more towards the autoimmune uh, complication, and I'm also concerned, so, man, there's a lot to worry about. So the autoimmune disorders that are the results of contracting viruses, what I would presume would happen, and I should really look this up before I really spout out too much, but I would believe that something that could cause an acute damage in someone, at least in a subset of victims of this virus, I would also assume that there would be a larger subset of people who would have some chronic complication from it. So especially if it's autoimmune, because remember, your immune system stays with you, and your immune system will be partially activated all the time for autoimmune diseases. So you need to go through a lot of effort in order to ramp down your immune response. So for instance, if you have, it's not Crohn's disease, what is it? If you're allergic to gluten, is that Crohn's disease? I get a lot of them mixed up. Celiac disease, sorry. So celiac disease, there are some immunological complications with that. So what happens is there's a epitope in some part of the wheat protein that looks similar to one of the hormones, one of the peptide hormones in your body. And so if you eat gluten and you're allergic to gluten, then if you eat it, your body starts producing antibodies against the gluten, and those antibodies will cross-react and attack your own peptide hormones as well. And this can cause intestinal problems, and can, in some rare instances, can cause skin conditions as well. So, and to stop that, you have to go through a lot of efforts, such as completely cut out gluten from your diet. So my concern right now is what happens when you get an autoimmune disease that is initiated by this virus. And if we know that the virus can probably live for a long time. There's one case up to 90 days of testing positive for the coronavirus after the onset of symptoms, or 92 days. And they made it seem like it was a rare case, but we aren't going out and testing people over and over again to make sure it's completely out of their system. We just say, okay, you tested negative twice, or you've been without symptoms for over a week, therefore you've cleared it out of your system. That's basically how the United States and a lot of Western countries have gone about it, whereas China was very not proactive, what would the word be? China was very active at, when they did decide to make it a very big deal and really crack down on it, they did. And so they did a lot more testing, and with that extensive testing, they were able to find someone who had tested positive 92 days after their initial infection. So if you have this autoimmune disease and it's initiated by the proteins that are caused by the virus, then if those proteins are still in your body 90 days later, that's probably going to mean your immune system is at least partially ramped up against the virus proteins. And that means whatever autoimmune disease is aggravated by those proteins will be aggravated for 90 days straight, possibly longer. So yeah, I really suggest that in the future we should be taking autoantibody tests, where basically testing for autoimmune diseases that are associated with demyelinating events, that are associated with hormone dysregulation, because we're probably going to be suffering from those things in the upcoming year. My guess, at a higher rate than normal, we are probably going to be suffering with those types of diseases. So, yeah, let's keep on going. And actually, this Guillain-Barré syndrome, let's look this up. Guillain-Barré syndrome, and can that cause tinnitus? Yeah, it looks like tinnitus isn't one of the symptoms. Okay. Continuing. I'm already down here. Sorry, I'm rambling. I'm drinking. I've been drinking. Anyways, the pathogenesis of the disease behind this manifestation is not fully understood yet. There is a strong evidence suggesting that COVID-19 virus uses ACE2 receptors to interact with host cells. This evidence is based on previous extensive SARS-CoV structural analyses that showed interactions between SARS-CoV virus and the ACE2 receptor, and because some marked sequence similarities between COVID-19 and SARS-CoV virus, it is hypothesized that COVID-19 virus pathogenesis is comparable. So that is true. However, there's also antibody-dependent enhancement that might also be playing a role in allowing the virus to infect immune cells. So I have another video on that if you want to watch it. But it is possible for coronaviruses to infect immune cells using your own antibodies, especially if those antibodies are not neutralizing or in high enough concentrations yet. Anyways, the ACE2 receptors are expressed on alveolar epithelial cells, intestinal enterocytes, which are the epithelial cells inside of your intestines that help absorb your food, and the arterial and venous endothelial cells. So a lot of layery or surfacey cells. However, in the brain, only the vascular cells were expressing ACE2 as the cell receptor, not the neurons. Yet this could be a potential mechanism for dissemination of the virus into the brain by the blood circulation. So ACE2 is not highly expressed in neurons. So how are we going to be seeing virus done to the neuron, or damage done to the neurons by the virus, if there are no ACE2 receptors on it? Well, it is possible that there are different receptors that the viruses can also use, because some spike proteins can interact with multiple receptors, not just one. So that could be a potential route. And what is another one? Yeah, and it could just be the damage that is caused from the inflammation of the viruses nearby, of the viruses infecting the cells nearby. Anyways, it is, and also the autoimmune diseases could be, Occam's razor. That's probably what's causing the majority of the problems. Anyways, it is also hypothesized that the virus can disseminate into nervous system through the olfactory bulb, in which sensory neurons connect the nasal cavity to the central nervous system by the axons, which terminate in the olfactory bulb and passes through the cribriform plate, and I'm not going to look this up. The route must be taken into consideration in cases of early phase COVID-19 affected patients whose exhibit loss of smell and taste. So that should be something to consider. If people have lost their sense of smell and taste, maybe their nervous system got infected, or at least some of the cells near the nervous system in the olfactory bulb got infected, and that could be causing damage to the nearby neurons, and that damage to the nearby neurons could be causing the anosmia and the lack of taste. Furthermore, in advanced stages of the disease, the neurological signs and symptoms observed in COVID-19 cases could be due to the effects of hypoxia, respiratory, and metabolic acidosis. So, yeah, there are other... Yeah, we should keep on going. The imaging modality of choice for the diagnosis of suspected cases of acute myelitis is MRI. T2-weighted fast spin echo and short tau inversion recovery are the best sequences to view the spinal cord lesions. I'm sure that this is just an algorithm that they use, but yeah, let's not get too deep in the muck. The latter being the most sensitive sequence. Okay, the role of MRI is not confined to demonstrate spinal cord lesions, but also to rule out other pathologies that may present with similar clinical symptoms. So doing an MRI is good for multiple reasons, because it could find, maybe you don't see these lesions, maybe you found something else different entirely, and that could help you decide, oh, this is the actual problem, not COVID-19. So in acute mellitus, signal changes tend to affect the central region of the cord and involve more than 2/3 of the cord's diameter, as well as the extended longitudinally and over more than one segment. The affected spinal cord segments appear hyperintense, so the high white signal on T2 and stir sequences. So those are these are the algorithms that I'm going to call them algorithms, but these are the techniques that they are using for the MRI. And this showed cord swelling and showed variable contrast enhancement. So in conclusion, finally, COVID-19 has been associated with several neurological complications. We present a case of acute mellitus as a neurological complication of COVID-19 infection that was admitted with paraplegia and urinary retention. The patient eventually improved and regained motor function, and in the current pandemic status, COVID-19 should be considered a differential diagnosis in patients presenting with loss of consciousness, ataxia, convulsions, status epilepticus, the epilepsy, and encephalitis, mellitus, or neuritis. So, in conclusion, what do I think about all of this? It is disconcerting to know that there's at least one human example, and keep in mind, this could have been happening in with a lot of the people who died, but we wouldn't have known, right? There are also videos circulating around where people just fell down, like they fell on the streets or they fell on the side of the road, and they just laid there. And I presumed that that was due to the breathing difficulties, which it looked like all those people had issues breathing. But it could also be due to some neurological issues that cause paraplegia, so that shouldn't be ruled out as well. So, and as I said, it is possible that in some of the severe cases, they're also getting this, the paraplegia, but if they're bedridden, how would you know? Unless you did an MRI. So, what this indicates to me is that this might be a more common issue than what we believe it to be now. And furthermore, I would also be worried of what are the chronic implications of a disease like this, because maybe you have acute problems in the people who come up into the clinics while the pandemic's going on, but give it a year, are there going to be a lot of people with chronic autoimmune diseases that are causing this paraplegia? What about in 10 years? 20 years? I mean, I like to think, though, that it's probably not going to be too bad, because at least with the mice studies, with coronaviruses that cause demyelinating events in mice, I believe they, if they survive the initial hump, if they don't get paralyzed over in the initial hump, then they don't end up paralyzed at all, if I remember correctly. So this could be an overreaction. But I am a little concerned, especially if this ends up being an endemic virus that ends up circulating the globe multiple times. Maybe the first time you get it, you don't have too much of an issue. Well, what happens when you get it the second time? Well, those same antibodies will probably spike even higher than the first time, and so maybe then you'll have more acute mellitus, maybe a higher likelihood of chronic mellitus. So, yeah, I'm concerned in that regard. But at least with this, there should be good medications to help alleviate a lot of the symptoms. And this guy survived, right? So this guy recovered. So whatever problem arose from this is probably not too permanent. So, what I'm gonna do is hang up. So thanks for listening, and if you found any of this interesting, please subscribe, and I will see you tomorrow.